Welcome, everybody. I'm delighted to have you all here. When I say you all, oh, actually, there are more people than just what I thought. Let me just say a quick hello. Most of you apparently are going to be watching the recording. Please do, because I think this is going to be a good one. But the people who are here get to please put comments in the chat that we can then address. Let me just see who we have here. Oh, hello, Dr. Ava. And Steve, I think it's Steve and not Steven. So hello, Steve, and Gina Kwan, and the other Gina Jones, and Michael. Hello, Michael, and Bill Spring. Thank you, and Gail Fox. Hello, Gail, and JFB. Forgive me for calling you that, but Jean-Francois, and Joel Green, and Asan. Hello, Asan, and iPhone, and Laura's iPhone. All right, so let me get back to the beginning. So this is now being recorded. So let me see if I can get this working right. So here are my slides, and I want to share my screen. I get nervous about this, as you all know, and I'm going here. And now I'm going to share, and you're going to tell me, did I succeed? Allow. Do you see it?
No,
I
Martha, it's a black screen on mine. It
Damn it.
says Martha has started screen sharing, but I don't see anything.
Okay. Wow. I mean, Gina Kwan. Gina Kwan. Oh, do you see it
There
now?
it is. Yes, I see.
Now we
Yes.
can see it.
And now it's here. Hooray.
Yes, you do. All right. Now, do you see it now? And so, for example, oh my God, I don't know how that happened. A little praying, I guess. Do you see this next slide?
Yes.
Oh, you do. Oh, praise
Yes.
the Lord. Praise the Lord. All right. Thank you all. And let me just move it. And I think we're good. And let me just get this a little larger. And here we are. So, what was that first slide? Okay. So, integrating the analytic wisdom. And welcome, everybody. I'm Martha Stark. Whatever. Anyway, integrating the analytic wisdom of the left brain or the observing ego with the emotional relational wisdom of the right brain, which in essence is what my optimally stressful, growth incentivizing, destabilizing conflict statements, which are featured in Model 1 of the Stark method, that's what they're doing. I'm delighted to say. All right, so for some of you, it's like, yeah, we've seen this a million times. And for others of you, it's sort of, oh, wow, who knew? So let me give you first a broad strokes overview of what I now call, it's only been the last year that I've been calling it this, the Stark method of psychodynamic synergy. 5 interactive and mutually enhancing modes of therapeutic action. It's not that you do one and then the next and then the next, not at all. Over the course of a session, you might well be either seamlessly or not so seamlessly shifting back and forth between 1 and 4 and 2 and 3 and 5, and you might not even know you're doing it. And I, who actually am the creator of this, even I, it's not like I'm busy thinking, so like, I'm going to go to Model 3 now. But it's so built into me that sort of like it's become more intuitive. And then certainly afterwards, if I were to think about it, be disciplined enough to sort of review what had happened, then I'd realize, I was mostly working in Model 2, but then Model 4, and then some Model 1. So here we go briefly. Model 1, the interpretive perspective of classical psychoanalysis. And I have 2 sentences that sort of capture where it was, there shall ego be, Freud, or Sir Francis Bacon, who said, knowledge itself is power. So, Model 1 is about facilitating the patient's evolving from resistance, which is the defense, said Freud, I'm saying it too, to insight. Although I have to have the adaptation starting with the letter A. So I'm going to call it awareness. So Model 1 is facilitating the evolving of the patient from the defense of resistance to the adaptation of awareness. Model 2, the deficiency compensation or corrective provision perspective of self-psychology and other deficit theories. And Semrad, my dear mentor, pretending that it can be when it can't is how people break their hearts. And this is about relentless hope. My term, relentless hope, advancing the patient from relentless hope, which is that's the defense in Model 2, because of the structural deficits or the self deficits, the impaired capacity to be a good parent unto oneself. Because of that, there is then a relentless pursuit of external provision of the caregiving that one never reliably and consistently got as a little one. And so the relentless hope speaks to a refusal to confront and grieve the reality of the objects of our desire, whether it's the infantile object, the transference object, or contemporary objects, a refusal to confront and grieve the reality of their limitations, separateness, and immutability, the fact that they can't be forced to change. And thus, the relentless hope, which speaks to an impaired capacity to be a good parent unto oneself. That's self-psychology. Model 3, the intersubjective perspective of contemporary relational theory. Whereas Model 1's one person, Model 2 is 1.5 person psychology, Model 3 is a 2-person psychology, intersubjectivity. We think Jessica Benjamin and folks at the William Allenson White Institute and others, Owen Rennick and others, Darlene Ehrenberg, Stephen Mitchell, may rest in peace, Jay Greenberg, et cetera, et cetera. So the hallmark, this is what I said, the hallmark of a successful projective identification is the therapist's ability to tolerate what the patient finds intolerable. So projective identification and negotiating at Darlene Ehrenberg's intimate edge of authentic relatedness is very much at the heart of the therapeutic action in Model 3. Model 4, an existential humanistic approach. And I always want to thank Gina Kwan for this one. She kind of helped me with this one, quite frankly. An existential humanistic approach to accessing the private self, easing loneliness, and finding meaning in despair. And so we have 2 of these. One of these, it was Ehsan who had to remind me how to say this one for Winnicott. It is a joy to be hidden, but a disaster not to be found. And Simon and Garfunkel, a rock feels no pain and an island never cries. The essence of Model 4. Model 5, a quantum neuroscientific approach to completing the trauma. So in the bodily sense, hello, Ed, to completing the trauma and liberating latent potential. The body remembers, said Bessel, even when the patient does not. All right, moving along here. So Model 1, structural conflict. Some of us old timers know to call it structural conflict, neurotic conflictedness, or the neurotic. Not that somebody is simply neurotic, they're somebody with neurotic features, but for our purposes here, I'm going to say the neurotic. With it being understood, we all have aspects of all 5 of these. All of us do. Model 2, self-psychological, yes. Structural deficit, impaired capacity. Narcissistic woundedness, narcissistic vulnerability, the narcissist. If we had to choose one word, people always say, well, what's the diagnosis? I'm not really all about diagnosis, but if I had to, then all right, the narcissist. Model 3, relational conflict. Thank you, Stephen Mitchell and others who have talked about relational conflict. Now, because I have to have an N word, neurotic conflictedness, narcissistic vulnerability, noxious relatedness. And this is the character disorder, or more extremely, the borderline. Model 4, relational deficit. And this is where I always say, thank you, dear Larry Hedges, for making me have my Model 4. And the symmetry, you have to agree, is just kind of cool. Structural conflict, Model 1, structural deficit, Model 2. Relational conflict, Model 3, and relational deficit, Model 4, like, yes. And this is now non-relatedness. There's the N word, affective non-relatedness, said Arnie Modell. And now we have the schizoid, we have the addict. Yeah, that was a newer addition. I sort of really got that, which is often a very private matter. And the outlier. So neurodivergence kind of fits in here as well. And then finally, Model 5, analysis paralysis, or neural entrenchment. This is when there is non-action, non-actualizing, non-action, the N-word. Individuals who are in a state of paralysis, tethered to their traumatogenic past, trapped in implicitly held old bad embodied memories, narratives, deeply ingrained limiting beliefs, as is described by some, and conditioned relational expectations. A lot of big words, but basically those are the different ways that Model 5 folks tend to describe what needs to be addressed. Okay, so I call this Stark method a CARES approach to deep embodied healing. CARES. C is cognitive, privilege is thinking. A is affective, privilege is feeling or emotion. R is relational, privilege is enactments, or actually, I think, reenactments. E, existential, privilege is the search for meaning. Whether nihilism or existentialism, the more evolved existentialism. S for synaptic, so CARES, C-A-R-E-S, privileges traumatic embodied memories and the deeply entrenched narratives that emerged as a result. That become the disempowering and distorted filters through which the patient then will experience self, others, and the world. Or if we're thinking more in terms of the neuroscientific, of the quantum piece, so neuroscientific is the synaptic, but the more quantum piece is superpositional. There's an S, the existence of multiple possible states simultaneously. And I've come increasingly to appreciate what that really means. It's sort of like there'll be a certain something. It's sort of like the particle wave duality of quantum theory. Do I understand quantum theory? Absolutely not. But in any event, the particle wave duality, the observer effect, and in essence, at the end of the day, the Stark method, as I have worked it and defined it, has to do with how you position yourself in relation to something that had originally been a traumatic stressor, which gave rise to all sorts of old bad narratives and rigid defenses. But ultimately, that they're same thing, but as a result of working it through and processing it and recontextualizing it, reframing it, grieving, you can evolve to making that their very thing that had been a traumatic stressor, making it an optimal stressor. And optimal stressors provide impetus and opportunity for us not just to defend, rigidly defend, but to adaptively respond. Oh, so that what had been a traumatic stressor becomes an optimal stressor. What had been a rigid defense becomes a more resilient adaptation. And my whole model is about evolving from rigid defense, the R words, to more resilient adaptation, the A words. Whew. Oh, that felt good to say that. All right, so there you go. Moving on. So the agents for transformation, the catalysts for change, because at the end of the day, this is about no pain, no gain. Okay, it's not just all nicey nice, 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 which is all good, and that's important backdrop. And in September, thank you, Gina Kwan and Teresa Tisdale at the Center for Christianity and Psychoanalysis. I got that right, Gina. I'll be doing a 2-hour presentation on Saturday, September 20th, and I'll talk much more about the holding and the provocation. And I hope you all will sign up for that. And thank you, Gina, for that. All right. I love the smiles of you people. Thank you so much. All right. So anyway, the agents for transformation. So yes, against the backdrop of the holding, yes, but there will now be a particular catalyst for change. And coming up with one word, here you go. Model 1, interpreting. Sort of like, well, duh, this is a classical psychoanalytic, it's more cognitive, whatever. So to resolve structural conflict, and we're going to focus on that today. Model 2, grieving. Grieving, it's not just about empathic attunement, that sort of backdrop, that's the holding. But in model 2, though not all self-psychologists are as focused on optimal frustration, optimal disillusionment that gets worked through, and then there are the adaptive transmuting or structure building internalizations. Not all self-psychologists say that, but some do, and I do. So here we go. I'm afraid to ask Dr. Ava at some point. I'm going to ask her that. But anyway, so self-psychological grieving is at the heart to resolve structural deficit. Okay. Model 3, the contemporary relational intersubjective perspective, negotiating. So whereas interpreting is what the therapist does, grieving is what the patient does, and negotiating is what patient and therapist do together. All right, model 4, that's to resolve relational conflict. Model 4, now we need to resolve relational deficit. And now deficits in terms of the relatedness between patient and therapist. Now we talk about surrendering. And this is where I now talk about Ofra Eschel's beautiful concept of the emergence of analytic oneness, or Michael Balint's concept of creating a harmonious, interpenetrating mix-up. I mean, or blissful, peaceful harmony, a merger. I mean, I just even saying that calms me. So surrendering, so it's about surrendering. That's model 4. And then model 5, I sort of had to do 3 words because it covers so many different sort of approaches. Disentangling from the toxicity of the past, rescripting, and then updating. To resolve psychic inertia and neural entrenchment. All right, moving on. Therapeutic goal. This you would sort of know. Enhancement of introspective knowledge, insight into internal conflictedness. Model 2, belated opportunity for grieving, internalization, and evolving to a place of acceptance. A safe space for grieving lifelong heartbreak. The other models do not emphasize that. Model 2 does. Model 3, navigation of transference, countertransference, entanglement, and intersubjective messiness a la Edtronic. And model 4, benign regression to analytic oneness and a new beginning. And we're thinking Winnicott, and we're thinking Balint, and we're thinking Ofra Eschel, and we're thinking Arnie Modell, and we're thinking a lot of people. And we're thinking about what probably all of us on some level are trying to do, regress to redo, so there can be a reset. Okay, and model 5, here we focus in more in order to actualize quantum possibilities, dramatic, jolting, and repeated juxtaposition of old bad with new good. And thank you for letting me say old bad and new good. I've already earlier described all the different old bads that there can be, narratives and limiting beliefs and emotional learnings, et cetera, with new good, envisioned things. Oh, there you go. That's that thing I bought from Synergy. The Synergy Compass that I bought from Shutterstock. Okay. So the Stark method, an integrative approach, one that involves the complex interplay of all 5 models, each gaining momentum by virtue of advancement in the other 4. In essence, the models are interdependent, none more important than any of the others, nor is there a progression. All 5 operate, one of my favorite words, synergistically, to capitalize upon the therapeutic provision of optimal stress. And by the way, people say, well, in model 4, where's the stressor? Well, in fact, in order to keep them in the relationship and to highlight and speak to how conflicted they are about even being in relationship and daring to expose the true self. And as you work to facilitate their surrendering to harmonious interpenetrating mix-up and analytic oneness, believe me, there's the optimal stressor. There's the optimal stressor. We do it real nice like, but by the way, that is tricky. And these are often the patients who, and when cases are presented to me in the spot supervision sessions, if I hear that sort of like, well, the patient's supposed to come each week, but now, they kind of come 3 weeks out of 4. I'm sort of privately thinking, although usually I just say, oh, kind of thinking model 4 here maybe, at least to describe some aspect of their engagement with the world, with life, and with the world of objects. Okay, let's see. Generate ongoing, iterative healing cycles of disruption in reaction to challenge, and then repair or recovery in response to support, and by tapping into the underlying resilience of the patient, their innate capacity to cope with optimal stress, and advancement from old bad, disempowering, and distorted narratives was the word I decided to use. Could have used beliefs, emotional learnings, whatever, to new good, more empowering, and more reality-based narratives. Variously described as, core beliefs, emotional learnings, mental schemas, relational expectations. Larry Hedges talks a lot about those, or a la Carlin Lyons Ruth and plenty of others now, implicit relational knowing. Okay, here we go. From structural conflict to structural collaboration. All right, so Freud's, okay, this is an interesting section, and this is an interesting section. Freud's pre-structural, so prior to structural, Bipartite, two parts. He didn't specifically call it bipartite, but in essence, it was two parts. Model of the mind, which was prior to his structural model, which was tripartite, three parts. All right. So his pre-structural bipartite model of the mind, his earlier one, he evolved. It's all good. We evolve. Conceives of neurotic conflict, sort of his focus, his specialty, as a story about tension between an anxiety-provoking, dysregulated id drive, this is Freud, and an anxiety-assuaging, self-protective ego defense. The defense mobilized by an undeveloped ego made anxious in the face of the threatened breakthrough of an unruly id impulse. Freud employs his famous horse and rider metaphor to illustrate the process of working through, whereby the id is tamed and the ego is strengthened. Indeed, as adaptive resolution or adaptive solutions that are healthier and more empowering begin to emerge as part of the therapeutic process, ongoing, protracted, the need for defensive strategies gradually diminishes, described in classical psychoanalytic literature as working through the resistance. And those two little books represent my two books on working with resistance, one of which was working through the resistance, and the other a primer on working through the resistance. And I remember I'd finally written, it was my first book, Working Through the Resistance, at Jason Aronson, who later became my dear friend and is my dear, dear friend. So I get it all done. I poured my blood, sweat, and tears into it, working with the resistance. No, I guess it was working with the resistance, I guess is what I called it. And so Jay said, that's great, but I want you to write a second book before we put the first one out. And the second book is going to be called A Primer on Working with the Resistance. So like, oh shit, man. So anyway, I wrote a second book. And by the way, just for future reference, don't ever have a second book or another book called A Primer on, because it gets so easily forgotten. Very few people even remember. Even I've sort of forgotten that there was a second book, but it is different. And it does a lot more sort of the process. And I break down patient, therapist, whatever. Anyway, so here we go. And I was going to say something. Yes, when I learned about the classical psychoanalytic perspective and sort of anxiety and stuff like that, quite frankly, it didn't do much for me. For the first decades of my life, of my professional life, sort of anxiety, whatever. And then one day I sort of like got it, light dawns on Marblehead. Like it really is important to have your finger always on the pulse of the level of the patient's anxiety and capacity to tolerate further challenge. Because if indeed it's too much for them to handle, then the ego made anxious will put a lid on the id, will mobilize a rigid defense. But if the ego can more easily take it in its stride, then the ego will be able to channel, that now more evolved ego will be able to channel the energy, that what had been dysregulated of the id, into more constructive endeavors and healthier pursuits. And now I've just given away the horse and rider metaphor that Freud introduced us to. So I'll say it real quick, but it really does make sense to me. Now, it did take me some decades to grow into it. All right, so more specifically, this is Freud here. Initially, Freud's inexperienced rider, so just visualize this if you could. An undeveloped ego will be made anxious by her untamed horse, a dysregulated id, which will prompt the rider to rein her horse in other words, the ego, to mobilize its defenses to put a lid on the id. But as a result of training of both horse and rider and working through by both patient and therapist, Freud's now more experienced and more empowered rider, a now stronger and more insightful ego, will be now better able to manage her now tamer horse, a now better regulated and more adaptable id. Indeed, as a result of this training, this working through, whereby the horse, the id, is tamed and the rider, the ego, is strengthened, which is what Model 1 is about, the defensive need to rein the horse in gradually gives way to the adaptive capacity to give the horse free rein and skillfully to harness its power, so that its now modulated energy can be channeled into healthier pursuits and more constructive endeavors. Think sublimation, yes, Freud's masterfully skilled, precision-driven surgeon who was once a young child playing recklessly with knives. Horse and rider will now be able to move forward harmoniously in sync, no longer in conflict between, but in collaboration with, from conflict to collaboration. Because what was once neurotically jammed up has now evolved into something freer and more expansive, sort of some version of the particle wave duality of quantum theory. So, and this one, oh, there you go. There you go. And one of Freud's quotes here, I mean, no dummy, out of your vulnerabilities will come your strength. And so it's not like sort of like, well, you get rid of them and now you're going to be strong. But no, out of your rigid defenses as a result of working them through, will come your strength. I mean, just beautiful. I mean, we do it, we know it, but anyway, it's nice to read that. Okay, here we go. This, some of you know, it was in a previous seminar that I presented, but I'm going to do this to take off on talking about Model 1. So consider the following clinical moment. This had happened a few weeks ago. A patient of mine, upon hearing me answer the phone at the time of our appointment with a warm and expectant hello, responded, "You sounded surprised." Relevant data points. I've worked with this patient weekly for over 8 years. She always calls precisely on the dot. I always answer precisely on the dot. She had called on the dot that day, and I had answered on the dot that day, and yet she said, "You sounded surprised." I mean, candy from a baby on that one, sort of like, not guilty here. Anyway, my clinical formulation, this was a moment of pure projection. Usually, quite frankly, these things, when the patient perceives you as being a certain something, there are elements of truth in it, which is why suddenly what had been Model 1 becomes Model 3, an intersubjective approach. And I appreciated Bill Springs sending me that email a couple weeks ago. Thank you, Bill. But anyway, becomes a Model 3. So my clinical formulation, though, in this instance, was that this was a moment of pure projection, the direct externalization of a disavowed psychic fragment. So clinical resolution, and then I'll give you my conflict statement. Once we explored her distorted perception of me as having been surprised, distorted perception, my patient came to appreciate that the idea of being surprised had in fact originated from within her and been projected onto me. We then traced this projection back to a series of traumatic childhood moments when she had quite literally been forgotten, lost track of by her mother, who had later responded with genuine surprise upon her daughter's sudden appearance. My patient's "you sounded surprised" was not at all about me, but a reverberation of that forgotten child's heartbreak, a psychic fragment disavowed and projected into the analytic field, where it was briefly mistaken for reality until it could be interpreted for what it really was. Okay, so this is what, and this true confession, I didn't get all this said at the time. This is, I said some version of this. This is a more sort of refined version, but I want to show you the power of optimally stressful growth incentivizing Model 1 conflict statements. So the first part's relatively easier to kind of come up with. On some level, you knew, say I to the patient, that I wasn't actually surprised to be hearing from you because you always call right on time, and I've always been here to pick right up without missing a beat. Okay, now, option 1. But, so this is the second half of a conflict statement, but deep down, there was another part of you, a younger, more vulnerable part, that was afraid I might have lost track of you, just as your mother had done so painfully all those many times when you were so very little, so breakable, and so in need of being remembered. And so for a moment, you feared that maybe I, too, might have forgotten our time. together. I knew this. I'd worked with her for 8 years. And yet she, despite all the work we'd done, she was still prone to, and here was an instance of her developing a negative neurotic transference, whereby in that moment she was experiencing me as her old bad mother who would forget. Okay. Option two, alternatively, the second part, I could have gone, but another part of you, younger, more tender, still carrying the ache of having been so often forgotten by your mother, feared that maybe I, too, had lost track of you, that maybe I, too, had let you slip from my mind, just as she had done all those many times when you were small, unprotected, and so deeply in need of being remembered. And so for a moment, it felt as though I, too, might have forgotten our time together. Okay, now let me say a little bit about the two sides of the brain, and then I'm going to move on here. So hemispheric synchronization to optimize brain health. Most people favor one hemisphere over the other, although EEG studies have demonstrated that humanity's greatest philosophers, thinkers, inventors, and artists use both sides equally. So how can both sides of the brain be activated at the same time in order to facilitate both the analytic wisdom of the left brain and the emotional relational wisdom of the right brain, such that those experiences can be integrated, one more tuned to the present future, left brain, and the other deriving more from the past, right brain? Now, inasmuch as each hemisphere, we all have known this from way back, has sensory and motor control of the opposite side of the body, moving both sides of the body at the same time and in a rhythmic fashion will obviously facilitate brain integration, as happens with walking, playing the piano, typing on a keyboard, or knitting. Even better will be cross-lateral movements, which involve crossing the midline of the body with an arm and or a leg. So too, any of the following brain exercises. And by the way, before I came on today, and I was kind of sitting here waiting for people to join me, and thank you, Jenny, for joining me early, and then Ed, I appreciate that, and then Joanne, and then Thaddeus, thank you for that. I was kind of here by my lonesome until you guys joined. I was doing some infinity signs. First with the one hand, my left hand, following it with my eyes so that I'm busy, crossing the midline of my body. And then with my right hand doing it so that I could sort of facilitate integration of both sides of my brain. All right, so here are some brain exercises. Write cursive with one hand and print with the other. Now, actually, I had a science teacher back in 10th grade biology, and she would draw a picture of a paramecium, with those cilia. And she would both draw the picture with one hand and then write with the other hand cilia, mitochondria, cytoplasm, or whatever. And she did that, and we would just sit there marveling. And I guess she was able to use both sides of her brain. So how about this one? This one I tried this and I almost blew my brain out. With one hand, draw the number 6, and at the same time, lift the foot on that side and make clockwise circles. Try it. I just about blew my brain out, and the poor little dog was listening there. All right, so toss, how about this one? 2 wads of paper into a wastebasket, one overhand and one underhand, and do it at the same time. And learn to juggle. That's the best one. That's a good one. And this was trying to juggle. I don't have that one down pat yet. I kind of throw the ball and practically throw it and hit the TV and throw it out the window and stuff. More work to be done on that one. So cross-lateral movements involve crossing the midline of the body with an arm and or a leg in order to activate both sides of the brain and in order to strengthen the fibrous band of connective tissue between the two sides to strengthen the corpus callosum. All right, this one, I don't know whether I embarrass myself here or not. Your more visual right brain tries to say the color, but your more verbal left brain insists upon saying the word. So which way is more natural for you? I guess I'm going to embarrass myself. Here we go. I feel comfortable with you guys, so I'm going to do it. First, I'm going to read it, and then I'm going to try to say the color. Okay. Blue, yellow, black, red, blue, orange, green, purple, red, black, red, orange, green, and now I'm a little self-conscious. Yellow, blue, yeah, blue, um, black, red, purple, yellow. So those are the words. Now I'm going to try to say the colors. So the words actually didn't do, maybe I have done a little better job of integrating both sides. Now I'm going to try to say the colors. Okay. Red, blue, yellow, green, black, red, blue, yellow, black, red, a green, a darker green, a yellow, a dark green, blue, a black, red, green. I did better than I usually do. Thank you, Dr. Weiner, for smiling on that one. I think I did a better job than usual because I'm using both the analytic wisdom of my left brain and my emotional relational wisdom of my right brain and wanting to do a good job here for you all. So I think I think it's good. All right, now real quickly, like a few more, and then I want to move on. So at any given moment in time, who knew one of your nostrils is more open than the other? And this alternates in a rhythmic fashion over the course of the day. So when your right nostril is more open, brainwave activity is greater in your left brain. By the same token, when your left nostril is more open, brainwave activity is greater in the right brain. Studies have documented this. You can deliberately, therefore, shift hemispheric dominance by closing one nostril and focusing your attention on breathing through the other nostril. As an exercise, do alternate nostril breathing to balance out your brain. Also, and I do this, I should have brought it to show you, but comparing the temperature, this is so cool, in one ear to the temperature in the other. So using a sensitive aural, A-U-R-A-L, not O-R-A-L. So an ear thermometer provides a clever and convenient way to assess hemispheric dominance. So Fred Schiffer, a psychiatrist up here. He and I had the privilege and pleasure of meeting every month for like years in a neuroscience study group with Bessel van der Kolk and John Rady and Fred Schiffer and some other sort of amazing people. And we met for years, once a month on a Monday evening. And Fred Schiffer was in that group. And I first learned about this from him years ago. So he wrote a book about it. Anyway, Fred Schiffer made the fascinating discovery that when one side of the brain is preferentially activated, then blood flow will be shunted away from the ear on that side toward the more centrally located cerebral cortex, such that the temperature in that ear will become somewhat lower than the temperature in the ear on the side of the brain not being activated. So maybe that's counterintuitive, but just reason it out. But when both sides of the brain are stimulated with bilateral alternating stimulation, which of course EMDR and plenty of other things do, and hopefully my conflict statements do, an aural thermometer will indeed show equalization of the temperatures in the ears. And then you get to integrate the wisdom of the left and the right sides of the brain. Is that exciting or not? Signifying hemispheric synchronization and optimization of brain functioning. Some of you are young, others of us are a little older, and quite frankly, any little something we can do to optimize the functioning of our brain, sort of like, I'm in. Okay, so try to balance your brain and then go back to read the chart on the previous slide and sort of see how you do. All right, now unilateral yogi nasal breathing, real quickly here. Yogic practice suggests, and scientific evidence confirms, that breathing through your right nostril will activate your sympathetic nervous system, creating an arousal state, whereas breathing through your left nostril will activate your parasympathetic nervous system, creating a stress alleviating state. So a hot tip, which I do sometimes, to facilitate sleep at night when you're trying to go to sleep or in the middle of the night if you've awakened at 3 or 4 in the morning, damn it. To facilitate sleep, lie on your right side and use the index finger on your right hand to close your right nostril and breathe slowly through your left nostril to activate the parasympathetic nervous system, and you'll fall asleep much faster. Okay. Finally, I think this is my last one of this, and then I'm moving on. Marcel Kinsborn performed a remarkable study, this is sort of good to know, in which he demonstrated that when subjects were asked to perform a verbal memory task, which is primarily a left brain function, they performed better when gazing to the right. Kinsborn ultimately concluded that looking to the right stimulates the left brain, and looking to the left stimulates the right brain. And I know when I'm formulating if I'm primarily focusing on formulating some very clever or smart interpretation, I tend to look up and to the right. I guess my body's wisdom knew that sort of like up there is where I might want to go to access the analytic wisdom in my left brain. Okay, but which means, at least in theory, that you can manipulate the side of your brain when you want to be more active by looking in the opposite contralateral direction. So when you want to win an argument with somebody, stand to their left so that you can look to your right, which has the additional advantage of not only engaging your rational left brain, but also forcing them to use their emotional right brain. Any technique that activates both sides of the brain will expedite the therapeutic action. And my interventions, quite frankly, in all 5, do attempt to do that. Any technique, which relies upon expedite therapeutic action, which relies upon being able to tap into both the emotional knowledge contained in the patient's right brain, along with its deep memory and felt embodied sense of the past, along with and the analytic wisdom of the patient's left brain, along with its clearer vision and guiding sense of the future. All right, moving on here. Now, okay, Freud's original drive, defense, conflict model, and many of you have studied Freud or did back then or do now or whatever. You read it, and people quote him, his drive, defense, conflict model. Oh, yes, the drive, defense, conflict model, rooted in his earlier bipartite model of the mind, conceptualized psychopathology. I just said this on an earlier slide. I'm returning it to it, as resulting from internal tension, I already said this, between a dysregulated id and an ego defense. Ego made anxious, putting a lid on the id. So again, an ego made anxious by the threatened breakthrough of the id impulse. And this is the id drive, ego defense, conflict model, bipartite. But I have found it clinically more useful, however, to broaden this, and he never really changed that, by the way. He never changed that, even after he introduced the superego, which was the third agency in the brain, the id, the ego, and the superego, becoming then the tripartite structural model of the mind. But he never got rid of his horse and rider analogy, never said, forget that. And nor did he no longer call it drive defense conflict. It could have been called theoretically drive prohibition conflict, but nobody calls it that. Or drive injunction conflict. But no, it was more id drive ego defense, not superego injunction. But that's okay. All right, so I've found it clinically more useful, however, to broaden this traditional conflict model as follows. So you'll see it's very similar, but a little different. My Model 1 conflict statements recast neurotic conflict as speaking not simply to a clash between impulse and constraining demand, that's the superego, but more expansively to simply more broadly, a state of internal dividedness between 2 poles inside. On the one hand, here we go, anxiety provoking, and please just sort of feel your way into this, anxiety provoking forces, pressing yes, which once accessed, modulated, and made more manageable as a result of working through, will become growth promoting and empowering. eventually fueling the patient's momentum. Tame the horse, right? Anxiety-provoking forces. And somebody cleverly had mentioned one time, sort of like, well, Martha, I know you're left-handed. And so like, well, I am, but how did you know? And they said, well, when you're talking about growth, promoting, and empowering, bammo, you go up with your left hand. This is, of course, a mirror reflection here. You go up with your left hand because that's the more powerful. And so like, well, you got that right. So anyway, and you, as you start to create yes and then no, see whether or not you intuitively go up with your right hand if you're right-handed, or up with your left hand if you are left-handed. So anxiety provoking, and my hand just goes up, I can't help it. Anxiety provoking forces, pressing yes. Sort of id related, which once worked through will become growth promoting and empowering, eventually fueling the patient's momentum on the one hand, and on the other hand, anxiety assuaging counter forces, resistant, defensive counter forces, insisting no, which, as long as they remain unnamed, unexamined, unchallenged, not worked through, will be growth impeding and disempowering. So the patient, and ultimately thwarting the patient's, not even just ultimately in the here and now. I want to change the word ultimately, thereby thwarting. I got to change that one on that slide, page 29. Thereby thwarting the patient's potential and getting the patient jammed up, neurotically conflicted. And I know I had been talking about the conflict between defiance, sort of from the id, and compliance, a little more from the superego. That's fine and that's all good. And I'm actually now even broadening that a little bit to just simply anxiety-provoking forces pressing yes, which aren't always necessarily just about defiance, but often are, but not always, on the one hand. And then on the other hand, this countermanding, this counter force, anxiety assuaging, anxiety relieving, insisting no, creating neurotic conflict, jammed up, struggling, model one. Okay, that's my broadening of Freud's more specific. You might almost sort of say, well, how's that different? It is a little different, quite frankly, but don't worry about it. Let's assume it's close to being the same. That's fine with me. And I love this one. At the heart of classical conflict theory, a beleaguered ego caught in the crossfire between yes and no. And the idea that those two phases are so close together, I just totally love it. All right. Indeed, most patients are conflicted. Wait a minute. Oh, this is not slide 63. I don't know why it says that. Indeed, most patients are conflicted about most things most of the time, including, of course, about getting better, letting go of old bad, and embracing new good, if you want generically to describe what getting better would entail. Model 1 conflict statements are therefore universally applicable interventions that target these states of internal dividedness or conflictedness. Everybody's ambivalent about something. By speaking these conflict statements, by speaking simultaneously to both the patient's defensive need, because elsewhere I talk a lot about evolving from defensive need to adaptive capacity, or from defensive reaction to adaptive response, or from mindless reaction to more mindful response. There are many different ways to describe it. Or from psychological rigidity, thank you, ACT, to psychological flexibility or resilience. There are many different ways to describe the evolving from this more rigid to this more resilient, from this less evolved to this more evolved. Anyway, so here I'm talking about it as these statements speak simultaneously to both the patient's defensive need to remain true to old bad, a right brain mediated position rooted in emotional survival and shaped by early relational experience, and the patient's adaptive capacity to begin over time to recognize and reflect upon the price paid for that defensive investment. A left brain mediated function that will evolve through repeated engagement with the very conflict statements that are calling it forth. because you are calling it forth with these conflict statements that say, you, oh left brain, you know that, the reality, comma, but you, right brain, old, bad, there and then, find yourself experiencing the world through the distorted lens of Okay. All right, so model one of the interpretive perspective of classical psychoanalysis. Conflict statements are designed not only to make explicit both sides of the neurotic conflict, but also to juxtapose those two sides in a way that creates, yes, an optimally stressful, growth incentivizing mismatch experience, which, by the way, is at the heart of all 5 of my models, which, by the way, is what is at the heart of all of the models, just not everybody's formulating it in quite that way. An obvious easy one is EMDR, left brain, right brain, left brain, right brain. New good, old bad, new good, old bad, objective, subjective, objective, subjective. I mean, all of them are sort of doing that. And that's where I always have to say, and I spoke directly with Dick Schwartz, who said, yeah, okay, right, IFS, we don't highlight that specifically, these mismatch experiences that are growth incentivizing, but sort of like, well, yeah, that is certainly part and parcel of what makes IFS so profoundly healing, effective. Okay, but anyway, so let's see, conflict setting, but also to juxtapose, right, those two sides in a way that creates optimally stressful, destabilizing, growth incentivizing mismatch experiences. This dialectical tension emerges between the patient's, I'm repeating here, adaptive capacity, left brain, but once worked through, ultimately growth promoting, right? The kid who used to play with the knives, but now is a skilled surgeon. Or we who had some issues as we were growing up, that were complicated childhood things. And we're therapists and we help others. All right. So we've, processed and worked stuff through. So this dialectical tension emerges between the patient's adaptive capacity to acknowledge, this is a more cognitive approach. Okay. Acknowledge an anxiety provoking, but once worked through, ultimately growth promoting and empowering psychological truth, whether about any of a number of things, but for example, about the price paid for staying loyal to old bad, and or the enlivening possibility of moving toward new good. So, or it could be psychological truth about the work yet to be done in order to extricate them. So it's any of a number of things that will ultimately make the defense more ego-dystonic. I'm leaping ahead. Okay, the dialectical tension emerges between the patient's adaptive capacity to acknowledge the anxiety-provoking psychological truth and her defensive need, anxiety assuaging, but in the moment and beyond, growth impeding, to resist acknowledging that truth because facing it stirs too much anxiety. So basically, conflict between the adaptive capacity to face, to confront, and to know, and the defensive need to flee. Okay. In other words, conflict statements are thoughtfully crafted to encourage the resistant, defensive patient to step back from the immediacy of the moment in order to become aware of the dividedness within her. Model 1 focuses on the internal dividedness. Now, again, I've said this before, but people will say, well, Model 4, that's kind of about the patient's conflict, isn't it? About, conflict internally? Yeah, but that conflict is about relatedness and revealing and exposing to someone else the precious, vulnerable, fragile, true self. And the conflictedness is about being in relationship. Model 1 is about the conflictedness in the example. Sorry, I know I always use it. If you're neurotically conflicted and jammed up about masturbating, you can be on an island and you're sort of like, do I do it or not? Do I do it or not? It doesn't really now involve anyone else because you're on an island. It's just you. It's truly internal. So anyway, conflict statements encourage the patient to step back from the immediacy of the moment in order to become aware of the dividedness within her between an anxiety-provoking psychic truth, this is a slightly different framing of it, that will ultimately be in her best interest adaptively to acknowledge. Defensively, not acknowledge, that's resistance. Adaptively, to acknowledge, even though doing so will evoke anxiety. And on the one hand, the way she then defensively positions herself so as not to have to know that truth, because allowing it into consciousness would feel too overwhelming. Here we go. You adaptively, we don't say the word adaptively to them, but we think it. You know that. But you, comma, dot, 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 comma, but you, made anxious, find yourself defensively thinking, feeling, or doing in order not to have to know. That's the heart of a conflict statement. So simple, and yet not the easiest thing in the world to create. I'll explain why in a moment. So with the therapist's finger ever on the pulse of the patient's level of anxiety and capacity to tolerate further corrective challenge, which is what we're talking about here with the mismatch experiences, the therapist will, whenever possible, alternately and repeatedly challenge the defense with, you know that, by, this is introducing a new something, thanks to Jim Herzog, and then later elaborated by Salman Akhtar, disruptive attunement and homeostatic attunement, their terms. Anyway, alternately and repeatedly challenge the defense with, you know that. I mean, they're trying not to know. So when you say you know that, it's sort of like, whoa, that's automatically a challenge. But again, you want to do it thoughtfully, gently, carefully, and your fingers ever on the pulse of the level of their anxiety and their capacity to tolerate challenge. Okay. Anyway, there's a lot of bad noise going on outside of me, but let's not worry about that. I don't think you can hear it. I can, you can't. All right. Challenge the defense, you know that, by directing the patient's attention to where the patient isn't, but to where the therapist would want the patient to go, namely to a healthier, albeit anxiety-provoking place, something that would promote more insight or self-reflective, introspective awareness of what's going on inside. So challenge by directing the patient's attention to elsewhere, to where the patient isn't, but to where the therapist would want the patient to go. That's disruptive attunement. So it's being attuned. You don't just suddenly introduce something that's just like, so, did you see any good TV last night? I mean, it's not that disruptive, but it's not exactly where the patient was. But it's attuned to sort of where potentially they really could, should be, and almost are, except for the fact that they're not. They're defended. They're resistant. They're not quite there. Okay, challenge the defense, you know that, disruptive attunement, and then support the defense. That does not mean you agree with it and say, yep, it's good that you do that. It's not about that. The empathic stance, which in essence this is a la Robert Stollerow, his earlier stuff where he talked about this. It's a decentering from your own experience, the therapist, decentering from your own subjectivity, decentering from it, and joining alongside the patient and taking on their experience, but only as if it becomes your own. It doesn't actually become your own, because where are you? Your subjectivity is over here. You decentered from it, and now you join alongside, and you're empathically attuned or immersed in it, or vicarious introspection or whatever. But it doesn't actually become yours. It's only as if it does. So that it's not about, you say, I agree with you. It's not even about I, because I is, you've decentered from it, but rather you're just getting it. So painful to be feeling this kind of regret. So angry. So angry when you think about how misunderstood you've always felt. So you're not saying, I agree with you, you should be feeling that way. It's so not about you. All right. So, and then support the defense by saying, after the comma in your mind, you think comma, but you find yourself thinking, feeling, or doing in order not to have to know. So you support by resonating empathically. You don't agree with them. It's not about that. By resonating empathically with where the patient is. And I'll give some examples, and you see that it's not like I'm saying, oh, yep, good to be that way. I'm not doing that. Okay, by resonating empathically with where the patient is, namely in a less healthy, albeit anxiety assuaging place. Okay, now disruptive attunement, enacted in the first part of the conflict statement, is aptly named because challenging the homeostatic balance, which is what you're doing, of the patient's defenses in an effort to make them more ego-dystonic, i.e., not a good thing, and ultimately something they will need to know they need to let go of, will indeed temporarily disrupt the dysfunctional homeostatic status quo of those defenses. Similarly, homeostatic attunement, enacted in the second part of the conflict statement, is aptly named because being attuned to where the patient is in the moment, always with compassion and never judgment, will indeed temporarily support the homeostatic balance of the patient's defenses. That is, the dysfunctional status quo of her maladaptive but ego-syntonic defenses. She's still clinging to them for dear life. So optimally stressful interventions, and again, I'm going to give you a lot of examples, are indeed designed to alternate between repeatedly and judiciously, between disruptive attunement, left brain, and homeostatic attunement, right brain. That is, between challenging and supporting the patient's defenses. Here we go. Repeatedly, judiciously, and strategically. So they're like, oh my God, we have to be strategic. Well, yeah. As part of many things we do. But you can tell that in order to formulate an effective conflict statement, in the second half, you need to have been able to enter so deeply into their experience, taking it on as if it were your own, that you really, vicarious introspection, that you really are able to put into words on the patient's behalf your sense of what it is in them that gets in the way of their doing the healthy thing, which is to let themselves know the psychological truth. So it's, yeah, just saying. Okay, so repeatedly, judiciously, and strategically leveraging the patient's anxiety, alternately increasing it by challenging the defense, and then decreasing the anxiety by supporting the defense to galvanize transformation and growth. Okay, hear this one. My dear sweet Gunner told me to kind of put this one in here. You know, that this ad about, I think, shampooing your hair. So wash, rinse, and repeat. Leveraging the patient's anxiety to incentivize change means anxiety-provoking challenge, anxiety assuaging support, and repeat over and over and over again. It's an ongoing process of disruption, repair in reaction to challenge and in response to support, and by tapping into the patient's underlying resilience, both their innate resilience and their adaptive resilience that they are in the process of acquiring as a result of the therapeutic work. Both innate and adaptive. Innate there from the get-go, adaptive is what they acquire over time, especially as a result of the good work that you are doing with them. Okay, in essence, conflict statements interpret the patient's internal conflictedness by highlighting both sides of her dividedness, with an eye to making explicit the left brain, right brain conflict within her. Again, repeating here, but I really want you to get this. The anxiety-provoking, but ultimately growth-promoting, left brain mediated adaptive capacity to know what is true, to know what's really going on inside, to know about the undertow, to know about the conflictedness, to know, in tension with the anxiety assuaging and self-protective, but ultimately growth impeding, not only ultimately, but in the here and now, right brain mediated defensive need to resist knowing. And this is a grateful thank you to Dr. Nina Savell Rockland for reminding me that defenses are, of course, not only anxiety assuaging, but also self-protective. And that's something I have not tended to emphasize. I kind of know it, but I had not thought to emphasize it. So thank you. Thank you, dear Nina. Okay, so here we go. Okay, so additionally, there's one other little extra thing that can happen with a conflict statement. So again, the first part of a conflict statement, you know that, highlights what we believe the patient, albeit reluctantly, has the adaptive capacity to acknowledge. So it makes her anxious. No pain, no gain. There's the pain. The second part, but you find yourself defensively thinking, feeling, or doing in order not to have to know, highlights what we believe happens for the patient when, made anxious, she finds herself defensively needing to resist knowing it. Now, often implicitly held within a conflict statement, is an unspoken third part, a gentle, unvoiced whisper that maybe, just maybe, a soft invitation that hints at the possibility that a part of the patient might be starting to wonder what it would feel like were she to move toward something new, something different, something more aligned with who she is wanting to become. Okay, please note that, as tempting as it might be for the therapist to highlight in the first portion of the conflict statement something that she wishes the patient already knew, if the patient does not yet know it, then it is important that the therapist resist the temptation to lead the witness in this way. So, for example, let's say that you start your conflict statement with, you know that your unresolved feelings about your father are making it hard for you to find an appropriate life partner. Now, although that might well be true, saying it to a patient who does not yet know it risks making her feel misunderstood and perhaps even more defensive. It is also, in effect, a kind of clinical shortcut, a subtle form of cheating that is fundamentally unfair to the patient. And it encourages false self sort of, oh yeah, oh yeah. When in fact, no, they didn't know that. They actually really didn't know that. Okay, here are some. Juxtapose left brain mediated, you know that, with right brain mediated, but you find yourself to generate these destabilizing, growth incentivizing mismatch experiences, the working through of which constitutes the therapeutic action in model 1. There you have it. Let's see if I can put my money where my mouth is here. You know that if you're ever to get on with your life, you'll have to let go of your conviction that your childhood scarred you forever. I mean, this is somebody who said, like, I don't know how I'm ever going to be able to move beyond my bad childhood. So now you're just saying it. You know that if you're ever to get on with your life, you'll have to let go of that sort of work to be done, your conviction that your childhood scarred you forever. Do they know that? Well, they don't like to think of it very often, but yeah, okay. Yeah, okay. They do. But it's hard not to feel like damaged goods when you grew up in a horribly abusive household with a mean and nasty mother who kept telling you that you were a loser. Okay. You're coming to understand that your anger can put people off. Now, we're not saying, well, you know, your anger can really put people off. We're highlighting what they know. You're coming to understand that your anger can put people off. You don't want to have so overstepped that they say, no, that's not true. That's, again, you've probably been cheating and you're not actually, it's not fair. So you have to say something that they don't like admitting it, but they do know that. So you're coming to understand. Now, how do we know that? Because they've been talking about the fact that they don't have any friends anymore because they get triggered all the time and they get angry. And you're just kind of putting it into a sentence and highlighting, kind of framing it. You're coming to understand that your anger can put people off, but you tell yourself that you have a right to be as angry as you want because of how much you have had to suffer over the years. I mean, that's interesting, right? I mean, and you entered so into their experience that you get it that they justify this because they've had to suffer so much. They really get to be as angry as they might want to. And the patient will then feel deeply understood. And they can then either pick up on the second part, yeah, I mean, listen, I had a horrible childhood, I've been scarred terribly, or they can say, yeah, I know. I mean, that's why I don't have any friends and I'm very lonely and I feel bad about that. They can do anything, but they're not going to say no. I mean, sort of like if you get it right, then, you know, there's a lot of possibilities in terms of how they then react defensively or respond adaptively, hopefully respond adaptively. All right, two more and then moving on. You know that if your relationship with Alana is to survive, you'll need to take at least some responsibility for the part you're playing in the incredibly abusive fights that the two of you have been having. They do know that. They don't like to think about it, but they know that. But you tell yourself that it isn't really your fault, because if she weren't so provocative, then you wouldn't have to be so vindictive. And they say, exactly. Yeah, right. But then and you get to then, if you want variations on this, you can repeat it again. And but you do also know that it might well be that you're going to lose the most important relationship you've ever had because of these incredibly destructive fights that you and she have. Nonetheless, you're just sort of feeling, damn it, if she could only get a handle on whatever, then you wouldn't have to be reacting in the way you do. So you can just sort of da, 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 da. All right. And then finally, you know that someday you'll have to let somebody in if you're ever to have a meaningful relationship. But in the moment, the thought of making yourself that vulnerable is simply intolerable, out of the question. There's no way you're willing to run the risk of being hurt ever again. Mm-hmm. All right, at heart, conflict statements then juxtapose right brain mediated defensive need rooted in emotional survival, that's the second half, with left brain mediated adaptive capacity oriented toward reflective growth, thereby generating these optimally stressful, destabilizing mismatch experiences strategically designed to promote hemispheric harmony and catalyze psychological transformation. In other words, conflict statements hold the tension between the regressive pull of same old, right brain, old bad, and the progressive potential, new good, future oriented, for something new, different, and compellingly better, and serve as bridges between the entrenched, conditioned reality of old bad, deriving from the there and then of the patient's past, and the enlivening quantum possibility of new good, emerging in the here and now of the therapeutic engagement. Now, in essence, dual awareness is being fostered when the patient is being asked to direct and integration of both sides of the brain, right? In the corpus callosum, strengthening that, the fibrous connection. Dual awareness is being fostered when the patient is being asked to direct her right brain attention to what she's experiencing in the moment, while at the same time being encouraged to engage her left brain capacity to step back, detach, reflect, and recover her objectivity. So it's not just bearing witness, though there's plenty of room for that, but bearing witness. And in the course that I had been teaching at William James College, people really we all kind of came to appreciate that if all you do all the time is bear witness to the early on traumas, then on some level, neurons that fire together wire together, and you're just sort of reinforcing old bad, old bad, old bad, and never introducing an antidote to, in the form of some kind of corrective challenge. You're never really introducing something that would challenge the dysfunctional status quo that you're bearing witness to. And parenthetically, though this is sort of, I'm ahead of myself here, but the challenge in Model 1, by the way, challenge is cognitive dissonance, which is in essence this. I don't emphasize that here, but I should. Cognitive dissonance. Model 2, affective disillusionment. Model 3, relational detoxification. That's the stressor. Model 4, existential dependence, encouraging them to surrender to that. And Model 5, quantum disentanglement. Anyway, I left way ahead of myself there, but those are the corrective challenges. Anyway, that hardly even made sense to me, and I'm the one who made it up, but be that as it may. All right, anyway, so simultaneously, both right brain attention to what she's experiencing in the moment, and at the same time, left brain capacity to step back, detach, reflect, and recover her objectivity. In the psychoanalytic literature, this distinction, of course, between experiencing something and observing it is described as a healthy split in the ego, not the borderline splitting, defensive splitting of good, bad, whatever, but this between the experiencing or participating ego, right brain, and the observing or reflecting ego, more left brain. Richard Sturba, Leston Havens, both of them. Dual awareness is one of the goals of any meaningful treatment. All right, dual awareness. I just love that picture. I just sort of think, I just love it. And there's the corpus callosum. You have to have an imagination to think that's the corpus callosum. A cross section. It's a cross section. So there you go. Well, that wouldn't really be it either, but whatever. So engaging both the analytic wisdom of the left brain observing ego and the emotional relational wisdom of the right brain experiencing ego, dual awareness. All right, now, the patient's inner conflictedness, okay, can take the form of either divergent conflict, coexisting voices, each carrying a truth, or convergent conflict, the emerging self as opposed by, so left hand or whatever, as opposed by a defensive silencing voice, putting a lid on the id. All right, let me say it again, then I'm going to show you a visual. Either divergent conflict, coexisting voices, each carrying a truth, or convergent conflict. Think of your hands and how they go. Convergent, converging versus diverging. The emerging self, right, as opposed by a defensive, ego made anxious, silencing voice. Tony Chris, actually. All right. Divergent conflict are classic either or dilemmas involving two mutually exclusive choices. Shall I wear my blue dress tonight or my red dress? A tension between two viable options, one that will be chosen, the other relinquished. No compromising, no compromise formations, just one or the other. Think of this. That's divergent conflict. Now, let me say, when people are trying to create, let me just sort of see here. Okay. Okay, let me say, I mean, thank you. You're coming to, okay, you're coming to, from Jenny Howe, you're coming to understand that your job will not allow you to take care of your needs. But you tell yourself, if you just work harder, someone else will see how you are suffering and take care of your needs for you. Yes. Yes, that's Jenny Howe. I mean, Huey. Sorry if I said that wrong. That's beautiful. Thank you, Jenny. That's exactly right. You put that in the chat. Bless you. All right. So now most people, but not Jenny here, but most people, when they try to come up with a conflict statement, they come up with, well, you know, you could whatever, but you could do whatever. And sort of like, it doesn't go anywhere. So so visual, this is the visual. You guys don't know it, but there's a horrible screeching sound of construction being done outside my window. But I'm going to stay focused here. All right, let me just see. Okay. Okay, but structural neurotic intrapsychic conflicts of classical psychoanalytic theory are best understood as convergent conflict. So Model 1 conflict statements are therefore designed to address these convergent, both and, not either or, conflicts with an eye to generating internal tension between anxiety provoking, I've said this 100 times, anxiety provoking, but ultimately growth promoting, empowering yes forces, and anxiety assuaging, but growth impeding, disempowering, resistant, defensive, no counter forces. Here's one. You know that you're playing with fire by being romantically involved with your boss. But it just feels so good that right now you're not quite yet prepared to end it. Model 1 conflict statements are of no use, however, for divergent either or conflicts. Indeed, you would not advance the therapeutic endeavor much were you to say to the patient, you know that you could wear your blue dress tonight, but you find yourself thinking that perhaps you should wear your red dress instead. I mean, that sort of like does nothing whatsoever. So like, well, yeah, I could wear the blue dress, or I could wear the red dress. That gets you nowhere. All right. All right, here are a few more, but my eye's on the time and I'm going to have you. So first challenge disruptive attunement by directing the patient's attention to where we would want her to go, and then support homeostatic attunement by resonating empathically with where she is. Let me just see. Okay, this one, this final one is going to be for Gail, and her daughter. Okay, you know that you won't feel truly fulfilled until you're able to get your thesis completed. But you continue to struggle, fearing that whatever you might write just wouldn't be good enough or capture well enough the essence of what you're trying to convey. You were told too many times by your father that you just weren't smart enough to make it in the world. That last part's not relevant. Anyway, slide 50, that one. All right, so moving on. Let me just move on here. Okay, this is convergent conflict. So for many of you who sort of do chess or whatever, so there's the queen. There's the queen there who has landed there, and lo and behold, the knight, I think that's probably the knight, the opponent's knight, sort of like, wow, because the queen landed there, I'm in a position, the knight, to take it, knock it over, take it off the board. That's a convergent conflict. Isn't that great? The queen's there, and the knight, the knight is, yeah, it's not a rook. Yeah, the rook is, yeah, I think this is the knight. Sort of like, that's a convergent conflict. I just love that image. It took me a while to get sort of like, well, that's a good visual for convergent conflict. All right, moving on. Okay, now placing the conflict where it belongs, my eyes on the time. Okay, by locating squarely within the patient, this is very important, within the patient herself, the conflict between what she knows and what she made anxious finds herself thinking, feeling, or doing in order to avoid that knowing. So we're placing the conflict squarely within the patient, not in the intersubjective space. The therapist is deftly sidestepping the potential for conflict between herself and the patient. So many cases are presented at conferences where it turns out patient and therapist are in a knockdown, drag-out fight, power struggle. And this is one way, for example, truly to avoid that. By highlighting what is in the patient and what then becomes in the intersubjective field, et cetera, and then also taking responsibility for what's in you. These conflict statements are very much about not just what you think. So you don't say to the patient, well, you could ask your parents for the money to support the treatment. And plenty of therapists will say that. You could ask your parents for the money. God knows they've volunteered plenty of times to support the treatment. You don't say that. You say, you know that you could ask your parents for the money to support the treatment. And how do you know that they know? Because they told you that their parents keep saying that. And that's how you know it. They know, you know that you could ask your parents for the money to support the treatment. But you do more. That makes them anxious, comma. But, and now you get to resonate with what you, because you have empathically entered into their experience and you understand what gets in the way of their asking their parents for the money. And you say, but you find yourself thinking, there are too many strings, or there have been too many strings. There's no way at all that I want to be beholden to my parents any longer. And so I feel that I just really can't risk asking them, taking them up on their offer to give me the money to support the treatment. So even though I know that, and now the patient may go on to say, even though I know that on some level I'm kind of shooting myself in the foot because now I won't be able to continue the therapy, nonetheless, it just feels like I'd pay too high a price. So you're back and forth, and who knows, maybe that patient does end up stopping, or maybe as a result of working things through, no, the two of you negotiate model 3 at your intimate edge and figure out a way for that to be sort of finessed and worked through. All right, and the healthier part of them sort of, rising to the fore, and the ego made anxious, less inclined to put a lid on letting themselves do the thing that really they should do, which is, for Christ's sakes, at least you can get the money from your parents. There were so many things they didn't give you, good they didn't give you, and bad they did give you. At least, for Christ's sakes, take the money, whatever. All right, but anyway, so here we are, placing the conflict where it belongs. The therapist is deftly sidestepping the potential for conflict between herself and the patient. More specifically, whenever the therapist introduces a conflict statement with, you know that. Those are magic words, you know that. But you can't cheat, it has to be something they do know. And you know they know it because they've said it to you. They don't like being reminded of it, but they do know it. By doing that, the therapist is gently forcing the patient to take ownership of what the patient, albeit begrudgingly, actually does know. Now, if instead the therapist, in a well-meaning but misguided attempt to urge the patient forward, simply resorts to telling the patient what she herself knows, not only will the therapist be running the risk of forcing the patient to become even more entrenched in her stance of defiant protest, but the therapist will also be depriving the patient of any real incentive to take responsibility for her own desire to get better. If the therapist is the one busy doing it, well, you could be asking your parents for the money, blah, 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 blah. All right, I don't know why these aren't advancing. Now, in other words, by way of the judicious and ongoing use of conflict statements that compel the patient to become aware of and to take responsibility for her state of internal dividedness about, for example, getting better, in short, her ambivalence. So elsewhere I talked about the neurotic, the neurotic defense of just relentless ambivalence and a reluctance to commit. So the pattern of non-commitment, a reluctance to commit, this relentless ambivalence torn apart inside by these forces and these forces. Okay, so the therapist will be able masterfully or mistressfully to avoid becoming deadlocked in a power struggle with the patient, a power struggle that can easily enough unfold. Think about when you've gotten in a power struggle with a patient. If the therapist takes it upon herself to represent the adaptive voice of reality, if the therapist takes it upon herself to say, you could borrow it from your mother, from your father, from your parents, by overzealously advocating for the patient to do the right or healthy thing, a position that in turn risks leaving the patient made anxious with no choice but to become the defensive voice of opposition. I don't know why this, okay. Honoring the present and holding space for change. So please also note the implicit message, my eye is on the time, implicit message delivered by the therapist in the second part of a conflict statement when she uses temporal expressions such as for now, right now, at the moment, in the moment, at this point in time. These expressions are deliberately chosen to honor the patient's current investment in a dysfunctional defense. It's very powerful at the moment, right now, for now. By inserting these time-bound qualifiers, the therapist is gently implying that the patient's defensive position, although in the present understandably entrenched, is not necessarily fixed or permanent, and that even if, for now, the patient would appear to be committed to holding on to the familiar defense, there remains the possibility that at another point in time, something new and different could potentially emerge. Do you see how that sort of, instead of just saying, but you're not wanting to, blah, 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 instead, but at this point in time, you're not wanting to, which suggests that there could be a later point in time where things might change. All right, now parenthetically, as we sit with our patients, we will often become aware of tension not only within them, but within ourselves as well. Dialectical tension between, on the one hand, our vision of who we think the patient could be, were she but adaptively able, willing to make healthier choices. We think about this sometimes with respect to our children. And what do we and what don't we challenge them on? All right, so on the one hand, our vision of who we think the patient could be and what she could have, were she but adaptively able, willing to make healthier, more evolved, more reflective, more thoughtful, more resilient choices. And on the other hand, our respect for the reality of who she is and for the choices, no matter how unhealthy, that she defensively finds herself feeling compelled to make, right? So many times you sat there and are you going to challenge or are you going to support? And which way do you go? And my God, if she could only just blah, 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 then I know that blah, 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 blah. And yet you also feel you ought to be honoring and respecting, the choices she has made. And so we are therefore, always struggling to find within ourselves an optimal balance. And there is no right or wrong. And sometimes we this, sometimes we that. And again, I've said before, over the course of a session, I probably make, I don't know, 12 to 15 or 20 to 25 mistakes where I realize, like, oh, I overshot the mark. Better backpedal a little bit, or sort of like, well, boy, I didn't push that one enough. I should have more. So getting the right balance, it's not just sort of obvious, and you get to make so many mistakes. And I have with my patients take back. So if I say something and I sort of get it that it didn't land right, I'll often say sort of, can I take that back? I didn't get that right, did I? And often the patient will say, no, you didn't. Yeah, you can take it back. And then I try it again. By the same token, they get to take back. We do that. We're negotiating. It really is an intersubjective something, even though sometimes we're focused on model 1, focused on 2, model 4, model 5, and not just model 3. All right, but anyway, so we ourselves are always struggling to find within ourselves an optimal balance between wanting the patient to change and therefore challenging her, perhaps somewhat impatiently. Have you ever found yourself impatient with a patient, or impatient with your child, or impatient with a parent whom you're trying to sort of get to go to get another consultation on something and they won't? And between wanting the patient to change and therefore challenging her, and accepting the reality, sober reality of who the patient is, and therefore supporting her. Okay, challenge, support. Do I challenge or support? Or perhaps do both. And I hope you get it by now. I'm suggesting that my 5 interventions in these 5 modes, classical psychoanalytic, self-psychological, contemporary relational, existential humanistic, quantum neuroscientific, and my model 6 will be somatic, spiritual, that all of them involve both challenge, thereby tapping into the analytic wisdom of the left brain, and support, thereby tapping into the emotional relational wisdom of the right brain. And so whether it's a conflict statement, model 1, or a disillusionment statement, model 2, or a relational intervention, or an accountability statement, model 3, or a facilitation statement, model 4, or a quantum disentanglement statement, model 5, we are ever busy creating optimally stressful, growth incentivizing mismatch experiences between challenge of old bad and support of new good, creating thereby internal tension and homeostatic imbalance, the working through of which is the heart of the therapeutic action, and helping the patient, facilitating the patient's evolving from rigidity to resilience, from being a caterpillar to becoming a beautiful butterfly. There you go. Amen. All right, here we go. Indeed, we all find ourselves sometimes very confused about what to do next. Not quite sure what to do right now. Do not follow and keep left. And sometimes we do find ourselves feeling about as trapped as that. Okay, next. Okay. Now, here we go. I'm moving, get my eyes are on the time. I really hope you guys have put stuff in the chat. Just no pressure. Put it in the chat. All right. I got to do a conflict statement. Um, you know that it would be important to me to put something in the chat for me to join Jenny's wonderful conflict statement. You know that that would mean a lot to me. But you find yourself thinking, I'll wait for someone else to do it, or I'm not sure maybe that I would get it right, and I don't want to sort of embarrass myself if maybe it's not quite right. And I think maybe I'll wait for someone else to do it. And that wasn't a very good conflict statement. Maybe I'll figure out a better one in a moment. All right, so anyway, this slide here, the creation of internal incentivizing tension. Now I'm zeroing in now here between the gain and the pain, okay, of clinging to defensive resistance. Here we go. Okay, overview, and this is sort of, I think, kind of almost the last section. Okay, from this is model 1, from defensive resistance to adaptive awareness. You get that by now. Whenever possible, this is review, the psychodynamic therapist targets the patient's resistance when in the moments she's working with the patient's resistance, or the fact that they're seen to be really neurotically conflicted, really jammed up and stuck in those moments, as opposed to in model 2, where they seem to be relentlessly pursuing that which we know will never happen, relentless hope, or in model 3, where they're compulsively and unwittingly reenacting unmastered early on relational traumas on the stage of the treatment or in their lives, or when they are keeping hidden what's most precious and most vulnerable and most true, or when they are just really entrenched and stuck and can't budge from the spot. So in those moments when they're jammed up, conflicted, neurotically jammed up, that's when we're focusing in on model 1. Let's see. Psychodynamic therapist targets the patient's resistance with optimally stressful interventions that offer a combination of anxiety-provoking but ultimately growth-promoting challenge of resistance and anxiety-assuaging but ultimately growth-impeding support of it. The net result of which will be the generation of destabilizing internal tension within the patient. Growth incentivizing mismatch experiences between old conditioned defensive bad and new corrected adaptive good, the ongoing working through of which to resolve the homeostatic imbalance will incrementally advance the patient from rigid resistance to resilient awareness. Now, more specifically, the arc of Model 1, from defensive resistance to adaptive awareness, at its core, Model 1 is a carefully titrated effort to guide the patient from deeply entrenched resistance toward increasingly resilient awareness, and more specifically from clinging to rigid, dysfunctional defenses, spelled wrong, defenses that had once felt self-protective and necessary, to cultivating ever-evolving insight into, I'm adding something here a little bit, cultivating ever-evolving insight into both the early origins of these defenses and the ways in which those defenses continue to operate in the present, and ultimately toward empowered capacity and readiness to relinquish them. As we know, because most defenses are sustained by ambivalence, do we know that now? Yep. They both serve the patient and the patient pays a price. I don't know if I have or haven't, from what I've said, gotten across the idea that we're ambivalent about just about everything, including our defenses. And that on the one hand, they protect us, but on the other hand, they create problems for us. So, for example, we're always late. Or, for example, we just can't get together our tax information, or we can't just complete our dissertation. So we know that, that our defenses, it's sort of, there's a price we pay. They're not working for us so well, combined with they do work for us, which is why we have them. So the defenses, again, are kind of compromise formations, which I'd emphasized more in previous lectures. They're compromise formations, so having it both ways, but not really. So, the ambivalence about our defenses, sort of, we're glad we have them, but we also know we have to pay a price for them. And conflict statements are intended to help the patient become ever more attuned to, ever more aware of, to gain ever more introspective, self-reflective insight into both where they came from, their early origins, and how they serve us, and also the price we pay for having them. Okay, now that, I don't know if I could repeat that sentence, but that said a lot. All right, the task then is gently to illuminate both sides of the patient's ambivalent attachment to old bad in order to shift what had once been, these lovely words, now my patients use these words, what had once been egosyntonic, meaning it really isn't a good thing to be having, but it works for them. It also doesn't work for them because they're ambivalent. And we used to talk about ambivalently charged, narcissistically cathected. But anyway, that used to be what people talked about. And I used to say that too, but I don't say that as much anymore. I could, but whatever. But ambivalently cathected, ambivalently invested with energy that both serves and it doesn't. There's both benefit and there's cost. There's both gain, secondary gain, and a pain. Okay, so both sides of that ambivalent attachment to old bad, in order to shift, that's the goal of these series of conflict statements and the treatment, the work, in order to shift what had once been egosyntonic toward what is now ego-dystonic. increasingly so, thereby setting the stage for incentivized change. That alone doesn't necessarily do it. So like, well, I know I pay a big price, and sort of like, well, I probably shouldn't keep doing it. They're not then necessarily all better, which is why, quite frankly, we have Model 2, we have Model 3, we have Model 4, we have Model 5, and we're going to have Model 6. Thank you, Ed Goodbody. So we're going to have, that alone, just the awareness. So even though Sir Francis Bacon said knowledge is the essential impetus for change. I forgot what the exact words. Knowledge is power. Knowledge is essential for power, but it's sufficient, but it's not. It's necessary, but it's not always sufficient. Let's just put it that way. Insight and awareness is probably, not always, but probably necessary, but not always sufficient. How about that? Whew. I think I got that right. All right. So from egosyntonic to ego-dystonic, the turning point in the therapeutic arc of Model 1. Now, if defenses are ever to be relinquished, they must first be experienced as ego-dystonic. That is, as no longer in sync with who the patient would want to be. Defenses that have long been egosyntonic must come to feel increasingly alien and costly, as we're highlighting for them the price they're paying for clinging to them, such that the pain of maintaining them begins to outweigh over time as a result of the working through and these conflict statements, and more particularly a price paid conflict statement, which is this next piece here. Okay, such that defenses that had long been egosyntonic must come to feel increasingly alien and costly, such that the pain of maintaining them begins to outweigh the secondary gain of still holding on. To that end, I've developed a particular kind of conflict statement to which I refer as a price paid conflict statement, designed specifically to create incentivizing internal tension in the patient by juxtaposing, sort of more specifically even than what we had been talking about, by juxtaposing her dawning awareness of just how costly her defenses are becoming, with an eye to making them more ego-dystonic, with her evolving recognition of just how deeply invested she has been in holding on to them even so. So not just the price paid, but what the real gain for her, secondary gain, has been for her in holding on to them. Because she wouldn't be holding on to them but for the fact that they serve her. And yet they cause turmoil, internal inner torment of the neurotic, relentless conflictedness and inner torment, and a reluctance and inability to commit, and ruminative and indecisive, and oh my God, and I can't get my taxes done, and I can't get the weight off, and I can't this, and I can't write my email to the whatever. I mean, I dealt with all those with patients earlier today. All right, whatever. Her dawning awareness of just how costly her defenses are becoming, with an eye to making them more ego-dystonic, with her evolving recognition of just how deeply invested she has been in holding on to them even so. We need to create space for her to be talking about how they serve her, with an eye to highlighting just how egosyntonic they are, have become over time, and are part of who she is. Like her need for perfection, or her need to be in control always, because the world around her has always felt, and even from childhood, has felt always so unpredictable and unreliable, and anything could happen. And so therefore a need to maintain control, and there's a real investment in being that way. So you make sure that the world around you doesn't get out of control, and so that you don't get out of control. So it serves you, and for people to come to realize with the defenses, both how they serve them and the price they pay. There's a lack of being able to be more expansive and freer, and to be more who they are, and to come more into who they would really want to be becoming, and so on. Whew, got myself all excited on that one. So in essence, price paid conflict statements. Here we go. Spotlight the patient's ambivalent attachment to her defenses. So in order to generate this internal dissonance, the therapist will, whenever possible, construct a specific kind of conflict statement, a price paid conflict statement designed to foster the patient's ever-evolving awareness of both the psychic pain and the emotional gain. Remember those, please. They rhyme. The psychic pain and the emotional gain of remaining invested in the dysfunction. So now this format, more specifically, it's still, you know that, but now more specifically, the pain, the price you pay, the cost. ... But you remain. Here's the gain, even so. Or you know that, price paid, but you remain invested in, even so. These carefully crafted formulations are intended to make the patient's ambivalently held defenses and narcissistically cathected, because they're deeply a part of oneself. I think I want to put that back in there, narcissistically cathected. I'll do that later. I'll get that back in there. Narcissistically cathected, because they become deeply a part of who the person experiences themselves as being. And again, remember, narcissism can be both unhealthy, right, and healthy. So narcissism, healthy narcissism and unhealthy narcissism. So part of a person's just both healthy and healthy narcissistic sense of who they are. Okay. These carefully crafted formulations are intended to make the patient's ambivalently held, narcissistically cathected defenses less egosyntonic and more egodystonic. And thereby, I hope people are writing in the chat, because I'm going to be wrapping up pretty soon here, and thereby to galvanize her to take action to resolve the internal dissonance and restore a new, more adaptive, homeostatic balance. Okay, here are some. So we first challenge the defense by directing the patient's attention, again, disruptive attunement, but more specifically to the pain, the cost, the price paid for old bad. And then support the defense by resonating empathically with the secondary gain, benefit, payoff of holding on to it even so. You know that you're paying a steep price for not taking seriously the toll your drinking is taking on your health and your life. Okay, page 65. Okay, good. Your drinking is taking on your health and your life, especially in light of the DUIs and your problems now at work. But at this point, you still feel reluctant to let it go because right now, and since your wife left, alcohol feels like the only real escape you have left in your life. You know that sooner or later, you'll need to confront the impact that extra weight is having on your health, physically, emotionally, and medically. But right now, the idea of giving up the comfort of food feels unbearable, especially when you're already feeling so deprived in so many other areas of your life. Now, these statements don't sound like, oh my God, yes, but a series of these statements are designed to ease the patient towards recognizing increasingly the price paid, the cost, the pain, as opposed to the gain, the secondary gain. We're trying to increase their awareness of the pain, even as they're understanding their investment in the gain. You know that keeping people at arm's length has left you feeling painfully isolated, disconnected, and desperately lonely. But right now, the idea of letting someone in feels far too risky because the fear of being hurt again feels greater than the possibility of being loved. Conflict statements can also highlight not only the patient's emotional investment in maintaining the comfort and familiarity of same old, their investment in same old, and the psychic cost of that misplaced loyalty to the past. So not only highlighting the patient's awareness of that, but also highlighting the enlivening possibility for the patient of being able to have something new, different, and compellingly better at some later point, a future not yet lived, but already imagined. So whether illuminating investment in or cost paid for or possibility of, however, the aim is always the same, namely, to render the defense ever less egosyntonic and ever more ego-dystonic, no longer seamlessly aligned with the self, but increasingly experienced as out of step with one's evolving preferred sense of self. By highlighting, this happens to be, wait a minute. Yeah, this happens to be one of my favorite slides. It is. By highlighting the growing disconnect between the gain, benefit, emotional payoff of holding on to old bad and the pain, cost, psychic toll of doing so. Again, left brain, right brain, left brain, right brain. The therapist begins gradually to shift the balance from the gain of old bad, the payoff that has sustained its egosyntonic grip, to the pain of old bad, the price paid that will eventually render the defense ego-dystonic. Indeed, Mono 1 price paid conflict statements are powerful tools in the therapist's armamentarium and in the patient's armamentarium, where they say, I know that I'm paying a big price by continuing to smoke. At least now I just smoke 1 cigarette a day instead of smoking a whole pack. And I know I'm paying a big price. I've got cancer. I know this is scary. I know I shouldn't be doing it, but somehow I just feel I just have to do it. I just have to do it because it's just so scary and hard for me. It's one of the few things that really gives me any kind of relief. And they do it. They create their own price paid conflict statement. So Model 1 price paid conflict statements are powerful tools in the therapist's armamentarium and in the patient's armamentarium because they generate ever increasing internal dissonance, tension between the defense's lingering appeal and its mounting psychological cost. This carefully cultivated dissonance will in time tip the scales away from the preservation of defense and towards its eventual relinquishment. Indeed, as we have, okay, good, 2 more slides. Indeed, as we have, I'm wondering if there's going to be a surprise for me. Let me see. I got a few surprises. I've got some surprises. Oh, thank you, thank you. Okay, moving along quickly. Thank you. There's some surprises here. Thank you. Indeed, and as we have repeatedly highlighted, introducing corrective challenge into a system will inevitably give rise to internal tension. This is actually a little important. Internal tension and a state of homeostatic imbalance. But states of disequilibrium, from an evolutionary point of view, cannot be tolerated indefinitely. As described by Walter B. Cannon, the wisdom of the body is such that it will automatically self-correct or self-right. That is, call upon its innate capacity to recover from adversity by taking effective action to adapt to it. This powerful tendency to resolve the internal tension created by the discomforting experience of mismatch. This is the wisdom of the body, the innate, intrinsic, inherent wisdom of the body to resolve the internal tension created by the discomforting experience of mismatch and to restore homeostatic balance and synchronization of the hemispheres will be what fuels the process of change ultimately. Not just this, but this certainly goes a long way. With each iterative healing cycle of disruption and repair, destabilization and restabilization, the system will propel itself forward from defensive resistance to adaptive awareness. Okay, here we go. Okay, a mnemonic to help you remember. Where id was, there shall ego be. You knew that one. Where unconscious was, there shall conscious be. You knew that one. Where resistance was, there shall insight or awareness be. Oh, yeah, okay, yes, that would follow. So where the treacherous undertow once was, and I talk about the undertow with my patients sometimes, That makes sense for them because you can't really always see it, but you can feel it, and it's treacherous indeed. Where the treacherous undertow once was, rendering the patient unconscious in certain ways, right? People are unconscious, dissociated, swept away by unseen emotional forces, there shall mindful presence be, empowering the patient to remain grounded, withstand the pull, and resist being swept away. As long as the gain is greater than the pain, here we go. As long as the gain is greater than the pain, the defense more ego-syntonic than ego-dystonic, the patient will maintain the defense and remain entrenched in her resistance. But as a result of the patient's ever-evolving awareness of both the psychic cost and the emotional investment, once the pain becomes greater than the gain, the defense more ego-dystonic than ego-syntonic, the stress and strain of the resulting cognitive and affective. That's not emphasized as much in classical psychoanalytic, but we get to put that in there. The resulting cognitive and affective dissonance between the pain and the gain will ultimately generate the impetus needed for the patient gradually to relinquish her attachment to defensive resistance in favor of a new and more adaptive awareness. And I think my final slide, in the prophetic words of Jelly Roll, accepting his country music award a few years ago, you don't change until the pain to remain the same is greater than the pain it takes to change. Amen. Well, that's a slight variant on what I said. Amen and thank you. All right, now I'm going to get rid of stop share, and I'm now going to be able to look at all you lovely people. I see right away, Gina Kwan. All right, now let me just, I think what I'm going to do, oh my God, you left me comments, didn't you? It's a little hard for me to see these, but I'm going to, I guess or did you have something more immediately you wanted to say, Gina, or will I go through my, no, okay. So I'm going to go through these and read these, but I love it. And this is a funny way for me to see, oh, here we go. Okay. Esan says hi, and Joanne says hi, and Ed is testing. He says hello. Shireen, Dr. Shireen, hello, Martha. Okay, it is like telling a story of the patient. Yeah. Okay, this is great, says Judith. Thank you, Judith. How about us ambidextrous people? LOL. You probably have both sides of your brain already balanced because you're busy using left and right. And that is interesting. It'd be interesting to know if the great philosophers and artists are already using both sides of their brain. Yeah. Yeah, that's very nice. I like that, Judith. Okay, Jenny, here was her. Let me read it again. So, Martha, yeah, you asked us to put example of conflict statements. Here's one I'll use later today. Thanks to your help. You're coming to the patient. You're coming to understand that your job will not allow you to take care of your needs. Yeah, you've worked on that as a result of that, right? This is the result of the patient walks in the door and we say, you understand that. It's like, no, this is based on what's been happening. All right, wait, let me just show something up here. Wait a minute. I'm sorry, I'm just trying to get rid of something here. Okay, good. Here we go. Oh, good. All these people. Let me just real quickly, oh my God, let me see, Shireen. Matreyi, good. And Donna Mahoney. Hello, Donna. And Lema. And let me just real quick, Therese. Yes, and your brother Bill already here. And Boriana, you've presented to me before. Brian. Hello, Brian. Yes. Hello, hello, and Marjata and Gail Fox. Oh, good. And Joel Green and iPhone and Judy Pillinger and Carol. Hello, Carol. Carol is absolutely brilliant. And Dorothy's iPhone and a few others. And forgive me if I haven't said hello. I can't see all of you. But anyway, I know you're here. All right, so let's look at this again. So this is Jenny. She says, you are coming to understand that your job will not allow you to take care of your needs, comma. But you tell yourself, if you just work harder, this is probably someone who has relentless hope. So though relentless hope is a Model 2 concept, the way Jenny is formulating it, it becomes a Model 1, incorporated into the second part of a conflict statement. But you tell yourself that if you just work harder, surely someone else will see how you are suffering and take care of your needs for you. And the patient is going to feel so understood from that. That's beautiful. Use it later, Jenny. That's beautiful. Yeah, will not allow you to. And you clearly listened and you understand their deep ambivalence about something. And you're helping to put it into words in the form of a conflict statement. And then before long, your patients are going to be busy creating their own. I do know that, but I also find myself feeling. Okay, Martha, says Gina, how might OCD fit into your models? Oh, very much so. Do you use it more as model 1, avoiding knowing through doing and thinking, or as model 5? It could be both, but avoiding taking real action and living, or perhaps as both. Yes, perhaps as both, which is what you guessed. I could say, well, the one that came to mind for me right away is, you know that as long as you struggle in the ways that you do with this god awful obsessing and indecisiveness and conflict around compliance versus defiance, whether you have to be good, you have to comply, or you get to be bad, you get to defy, that as long as you continue to struggle with this god awful conflict, that you will feel that you will that your life, you will feel so exhausted in your life. This is somebody who has said they do feel that so exhausted in your life. You know that as long as you continue to struggle in this way and we don't get it resolved, you will continue to feel that your life every single day is just a sheer marathon and just agony, comma. And yet the conflict, that deeply embedded conflict, that message that you always got from your damn mother, that you just gotta, the rules, the regulations, you just gotta, thou shalt, blah, 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 and thou shalt not, that her voice just resides so powerfully inside of you that it's very, very hard to sort of let go of that. So even though you know you pay a huge price for having it inside of you, that nagging voice inside of you, and that it makes everything so much harder and so much more complicated, nonetheless, its grip just feels so damn powerful that for your mother, you were just never good enough. You never quite got it right. You never complied enough. You never obeyed enough those rules. Huh. Well, I even got worked up. So I don't know. I hope they did. So anyway, thank you, Gina. I got a smile from you, a nice smile from you. All right, now let me just see. Can we? I think maybe yeah, you're focused here, aren't you? Do we mind? Does everybody see you primarily? Do we want me to be seen? Uh, just spotlight. Should I be spotlighted? Am I now spotlighted or whatever? All right. Anyway, so moving on. So Judith saying quantum disentanglement statement may overlap, yep, with the other models very completely, yep, very, very complexly. Most particularly with model 1, I think. Yes, and model 3. Can you speak more to how you'd formulate and articulate quantum disentanglement statements? Let me do that briefly. The focus is so not on model 5, but let me try to do that. In model 5, I more specifically am going to bring in and together, patient and I, it's co-created quantum disentanglement statements. And the patient and I together co-create, we write it down even to make sure we got it, and it can be very long. And we talk about how old dad is impacting them in a very vivid, heartfelt, gut, visceral, embodied, hello Ed, embodied way, and in the here and now, that because when they walk out into the world, because of the message they always got that you're just too fat, nobody's going to like you, nobody's ever going to love you because you're just too whatever, and you're this and you're that, and so they go into the world and they can hardly bear to, and they this and they that, whatever, comma, they can perhaps envision that at some point maybe they could feel free enough and comfortable enough with their body and who they are and what matters to them, blah, 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 that they could venture out into the world. And again, co-created, the patient and you co-creating the old bad and the price they've paid and the pain of it and the anguish and the heartbreak. And on the other hand, envisioning what could be. They walk out into the world, they feel confident, they feel good. So it has two parts. Everything has two parts, but that focus is sort of quite different. So anyway, I hope I did a little something there for you, Judith. Okay, Boriana, Dr. Stark, some people frown upon parents, oh yeah, paying for the treatment when the client is an adult. Could you say more about your perspective on that? Thank you. That's interesting. Let me say, for starters, I will never. I do have some grown-up people whose parents basically foot the bill, but I never am willing to get the payment directly from the parent. The parent has to get it to the kid who's a grown-up. And the kid has to at least take responsibility for getting it to me. Back in earlier days, when quite frankly I was much more rigid around the frame, I think it's sort of like, no, the patient has to pay. And furthermore, practically even forget insurance paying for it, because then they're not even suffering enough. They're not even paying out of their own pocket. I have so kind of relaxed on that sort of like, if that's the thing that needs to be for them to continue the treatment, then so the parent pays for it. Now, we might well then zero in on their entitlement, or they're a bit of a princess, or the price they pay for indeed accepting payment from their parent, and whether or not in the same sense of, we used to say that a reduced fee is sort of like that sort of in collusion with the patient's entitlement, and they're not then taking responsibility for paying the full fee. Again, on that, if you sort of look at it and examine it and maybe have some flexibility, and for patients who truly cannot afford your full fee, then to be willing for a time-limited period, and you do look at it, and you do think about it, whatever, to do that. So more flexibility. So I was trained in also, I was trained that I was walking down the street one time with my dear sweet Gunner, and there've been several times this has happened, and I run into a patient, and once I jumped into a bush. Or I had Gunner jump into the bush, whatever. Or how do you introduce? They don't even know you have a life partner. And you certainly don't say your patient, you say, hello. I used to be way more uptight about that than I am now. I don't necessarily say sort of like, oh, here's the love of my life, and oh, here you are. And by the way, you're the one I see on Tuesdays at whatever, but whatever. So if it gets talked about, I feel that more stuff can be done, especially if it enables the treatment to continue. So thank you, Boriana. That's my perspective. Merci. You mentioned model 1 person, model 2, 1.5 person, model 3, 2 person. Can you take further model 4? Yeah, that's good. So model 4, I think I want to say 2 as 1 person. Analytic oneness. Thank you, Ofrecio. Yeah. The emergence of 2 as 1. So 2 as 1. Or, yeah, I want to say that. 2 as 1. Okay. And then model 5, I want to say the envisioned third. So there are 3. The patient, I guess you could say 4, but the patient, there's my left hand again, the therapist, and then the envisioned. We in my group, we talked about the alchemy, the envisioned possibility of what could be. And so the envisioned third, obviously, take off on Thomas Ogden's analytic third. So the envisioned third, so 3 person. So model 5 is 3 person. But what did you say? Many people, model 5, oscillating person, model 5, oscillating. Many people, model 5, oscillating person. Okay, Judith, brings to mind Bob Newhart's Stop It episode, or Do It Already. But the transference need to be told what to do thing, but the transference need to be told what to do keeps the paralysis going. You can do this. But you're afraid you'll have to lose me and the treatment and your conviction that this is the best relationship you've ever had. Yeah, no, that's interesting. I like that. You know that you can do this. That's very nice. Yeah, that's very nice. You can do this. She has a lot of training in ego psychology and other things too. Anyway, you can do this, but you're afraid, yeah, that were you to do it, you know you can get better. But your fear is that were you to do that, you would lose me, you would lose the treatment, and your feeling and your sense that this, quite frankly, is the best relationship you've ever had, and that price feels. That's why with some of my people, actually, we have it that they can get all better, and we continue. It's not just they get better up, that's it, bye bye. It's sort of like, to some extent, you kind of grow old with them. I mean, obviously, they need to have the money to do that, but it's not just they get better and that's it, but rather we can continue. And yeah. I mean, I remember talking to the dear Anna Ornstein, and hello, Dr. Ava, very close friends they were, and with Paul. And Anna would say that, yeah, she would maintain contact with her patients and periodically might even see them. And I know that after I've officially ended with the patient, I will often, always want to do a 3 months later, 6 months later touch base, just to touch base, and then maybe yet another one 6 months later or a year later. I did that with my own therapist. I touched base with her every now and then just because if I wanted to. And that meant a lot to me. Okay, Model 6, you're not alone, and it's okay to not know. Thank you. Thank you, Judith. Do you know it's okay not to know? Yes, I do know it's okay not to know. Okay, Dr. Donna Mahoney. Love the Bob Newhart skit. What not to say. Yeah. Okay, Matri. Not just okay, but isn't it essential to know how little you know if one wants to begin to know? Yeah, that's right. Good to know what you do know, good to know what you don't know, it's good to know that it's okay not to know. All right, Ed, for one of my clients, oh, this is good. Thank you so much for your comments here. Oh, I see we're running over. Well, obviously, you guys can drop off if you need to, or you can stay, but this will all be the recording. Oh, and I am doing another one next week. I couldn't help myself. And I mentioned that maybe at the beginning, some of you heard it, but I couldn't help myself. So it's going to be on evocative memory and mentalizing capacity and developing the ability to grieve so that there can be adaptive transmitting internalizations. Thank you, Jean-Francois, for that nice smile. All right. And then the week after that, I start my free spot supervisions. And many of you are in it already. And those who aren't, I mean, just send an email and you're in. All right. Okay, and those I show on my private YouTube channel because we talk about specific patients. Okay, but this is on my public YouTube channel. Okay, let me see. Ed says, Ed, for one of my clients in analysis paralysis, so automatically he is too, thinking Model 5, you know you will only be free to be yourself. And this technique could have been you and she together co-create this. So the word would be, I know I will only be free, but that's fine. There's no problem. We'll go with you. If indeed it's a Model 5, if it's going to be Model 5, but it might be a Model 1. All right. You know you will only be free to be yourself when you complete your grief and anger over the abuse of your marriage. Yes, I love that that is a Model 1. And that's highlighting the work to be done and highlighting then, in essence, the price they pay by not yet being done with it. And also highlighting the possibility of when you are done with it, then you'll be free. Look at all of what he did in the first part. That is a Model 1. But it is a patient who is actually analysis paralysis and stuck in a marriage and just can't do the grieving and anger about the abuse in the marriage. So that's a beautiful example. Earlier I'd said it is about relentless hope. Jenny's was, but it's a Model 1 statement. And Ed's here is about a Model 5 situation of entangled with old bad stuff and the quantum and paralysis analysis and neural entrenchment and so on. But it's a Model 1, beautiful Model 1. I only got to the first half of it. You know you will only be free. I love it. So it would be, you know you will only be free to be yourself when you complete your grief and complete, not even do, but respectfully, when you complete your grief and anger. And obviously, we know anger is a part of grief, but he's actually spelled that out, and I'm glad he did. When you complete your grief and anger over the abuse. Thank you. It's not like we have to say over what goes on for you in your marriage, but rather over the abuse. It's been named as that over the course of their time together. We don't have to like sugarcoat over the abuse of your marriage, comma, Yet, we can say yet if we want, or we can say but, or we can say nonetheless. Yet, you find yourself drawn by desires, oh wow, to leave, this is a woman, to leave voice messages. Yes, yes, drawn just irretrievably, just desperately drawn, just unable to avoid it, drawn by the desire to leave voice messages for him. And oh, this is going to be some relentless hope, I bet, and expecting and hoping and praying that he will recognize. Oh, they're also a little abusive too, I bet. And they're angry, angry, angry. So you could have said to leave sort of angry and retaliatory or whatever it would be. Messages for him and expecting that he will recognize, oh, hoping that he'll have mentalizing capacity and be able to recognize how his behavior, hold in mind how his behavior might impact someone else. Okay. And expecting he will recognize the impact of his abusive behavior and then apologize. There's some relentless hope. I mean, Ed, that is, wait, oh, I'd have to stand up, but then you'd see I'm wearing my pajamas. So let me just, Donna smiled on that. Let me just applaud. That's beautiful. That like covered everything. And that's beautiful, Ed. And I know that, I mean, I'm assuming you spent a little time trying to formulate it, but by the way, it's so au naturel and it's so emerged and it gets it all done. So thank you. I love it. I love it. Thank you so much. All right, good. So now moving on. So here we have Dr. Ava. Thank you, Martha, for this overarching overview of such an amount of psychodynamic concepts. Thank you, Dr. Ava. And let me say, this group, my group, and I know just about most all of you, and I don't know all the people will be listening later, but I promise that this is co-created. I feel so held by you. I know that sounds sort of corny, but I feel so held by you. And some of you, I get that smile from Jean-Francois. I just love that. And I know that some of you already, brother and sister duo and others as well, had been at my in-person week-long training in Miami. It'll be February, this upcoming 2026, where you come and I get to see you in person. So I've actually seen you in person. I know Ed in person, Lauren. I mean, I know a lot of you in person. And of course, Gina, I mean, I know a lot of you in person, but some of you I just know, I guess, from this. I guess I haven't ever even seen Brian. I mean, in person. Right, even though I've known and adored Brian for years. But anyway, so anyway, you have helped to co-create this for me, and I feel really good about what I've been able to convey to you. I've learned even from these last 2 hours. Bless you all. Okay, moving on. So thank you, Dr. Ava. And I love having Dr. Ava here. And I see her and I think about Paulina and Anton. That's what I do. I think about both of them. Okay, Lema. And of course, Anna and Paul Ornstein, of course. Okay, Lema. Patient's internal conflict. Okay. To be successful in my current work, MD, this is the patient, is to accept that my father, whom I hate and who wanted me, to become an MD, was right. Oh, that's so good. That's so good. Yeah, that is a good conflict. Yes. Or that if somebody is going to get related to that is if somebody's going to let themselves get better, it means that sort of like they're letting their parents off the hook. And I guess the parents weren't that bad off, that awful after all, because look, I'm getting better and I'm now doing what I wanted to be doing and I'm doing it well. So let's see. So patient's internal conflict about being successful, letting themselves really claim that and take ownership of the fact that they're successful in their current work as a doctor, but is to accept, yeah, it gets them all jammed up that, God damn it, the father whom they just hated and who always wanted them to be a doctor was right. Sort of like, shit, man. You know, and a cousin to that is something, thank you so much, Lame, I love that. Hence, constantly feeling exhausted and hopeless, as in everything is futile. Yeah, right, because caught in a total horrible conflict there. Oh, that's beautiful, Lema. And for you to understand that, you and the patient to be coming to understand that is beautiful. What it reminds me of is a consultation I've done on a patient, forgive me if you know this one, but the patient came to me for a one-shot consultation, and she was 35, a lawyer. And come to find out, one-shot consultation, she hated being a lawyer, just hated it. And so we got to talking, and she said, well, she decided to be a lawyer because her father was a lawyer and had always wanted her to be a lawyer. And And she said, but I hate it. I hate being a lawyer. So I say, well, at least you've made your dad happy. And she said, my dad died 20 years ago. Do you get it? He never even knew she'd become a lawyer. He died when she was 15. But she felt carried inside of her. She felt she kind of needed to do this and had gone on to be a lawyer, even though she totally didn't want to. So that's a reverse something of where, whatever. But people do these things. They get all jammed up and they listen to messages and they do this, that, whatever. And with a conflict statement, we can sort of try to tease out the different aspects of the conflict. All right, so here, Dr. Donna Mahoney. Yes, she does a lot of teaching, Donna does, as do probably a lot of the rest of you too. Okay, Martha. Oh, I've benefited so much from your ability to synthesize, and your ability to show the interconnections is excellent. Oh, thank you. I'm using both sides of my brain. When I'm done, I'm going to stick that oral thermometer in my ear and I'm going to see if indeed both sides, or maybe I'll go back and see if I can read the colors and say the colors and feel it without getting all kind of jammed up. Okay, Martha, so benefits so much. And your ability to show the interconnections is excellent. And I love that you offer suggestions. Oh, in intervening, thank you so much. Ah, well, thank you, Donna. And thank you for your very sweet overtime support of me and my work. It means the world to me. Hi, Martha. Hello, Kay. All right, Gina Kwan. I have to go now. Thank you, Martha. I look forward to listening to the rest of the recording later. And yes, Gina, you're going to hear how much I love you. I just adore you. Okay, good. Jenny, Huey, I think it is Huey. Martha, I'm so grateful for your amazing thoughts and willingness to share. Like Gina, I look forward to watching the remainder of this recording and seeing you soon. All right, thank you. Okay, Model 6, The Art of Possibility. Xander, great book. Okay, great idea. Get better and continue. Ah, thank you, thank you. All right. Judy Pillager. Thank you so much, Martha. And I know they're almost done here. Thank you so much, Martha. And you could raise your hands, anybody, if you have a question in person. And for all the insightful questions, as always, look forward to re-listening to the recording. So much to think about. I mean, I'm going to have to listen to the recording in order to learn all of what I said. Conflict statements really feel, says Jean-Francois B., JFB. Conflict statements, I'm trying to get him to come to the Miami thing. I'm working on that. Conflict statements really feel as being central as a factor of therapeutic action as they impact dysfunctional defenses. Yes, and defenses are where it's at. Right. And you can always, if you want to shift into cognitive, Model 1. If you're going to be a little more focusing on affective, it might well be a little more about grieving. If you're going to shift a little bit more into the here and now of the intersubjective connectedness, then you'll be doing some relational interventions and accountability statements. And Model 4, if you're wanting to facilitate their regressing to redo in order for there to be a reset, and I always talk about scalar energy then a facilitation statement where you highlight a part of them yearning and longing to be seen, heard, understood, but another part of them terrified of being found. That's a facilitation statement where you're naming both sides. You're ever busy naming both sides, and then a quantum disentanglement statement. I kind of did an example earlier for Judith. Okay, so Jean-Francois. We also know that the emotional connection of the therapeutic relationship is also a central factor of change. Right, so that's why I say analytic wisdom of the left brain and emotional relational wisdom of the right brain. I'm wondering how to theoretically integrate those two aspects in the relinquishing of old bad. Yes, they're always intertwined, though it's what is being privileged in the moment. So in the moment, cognitive is being privileged from Model 1. In the moment, affective is being privileged, and emotional attunement to the patient's heartbreak, lifelong heartbreak. In the moment in Model 3, their relatedness and their authentic being and so on is being focused. Their old bad, distorted sense that everybody's going to be critical or everybody's going to end up abandoning or everybody this, that, whatever. And in Model 4, what's being privileged is sort of somehow making meaning of stuff and just feeling lost and confused. And what is one's connection really with the world anyhow, anyway? And Model 5, yes, when they're just stuck, they just ground to a halt. and they want desperately to get out of it, and it's old bad. They have the big T traumas, little T traumas, and all the narratives, the old bad, disempowering emotional learnings and relational expectations that derive from all those old bad embodied things, and that are a story about them in the here and now. The sobering, entrenched, conditioned reality of old bad, and that gets named emotionally, physically, intellectually, all sorts of whatever in Model 5 by patient and therapist. And then in the second part of a quantum disentanglement statement, more the envisioning with the forward-thinking left brain, but also still being able to get stuff said that involves the body and all sorts of everything. It's co-created. It's about cognitive, affective, and relational at the end and future. And at the end of the day, and again, Model 6 will be spiritual, which I don't emphasize as much, but I will get to that. It's about everything. So in answer to your very good question, ultimately, before they really relinquish it, there really will be elements of cognitive, affective, relational, existential, which was Model 4, and then quantum and synaptic, Model 5. It'll be all of those. And then Model 6, spiritual. I don't emphasize it, but hopefully. And you know that when I add Model 6, somatic dash spiritual, then my approach will be called a caress method. CARESS. I got lucky on that one. All right, so here, Brian. Oh, so good to hear from Brian. Iterative cycles of your ever-evolving models. Thanks, Martha. Brilliant as ever. Thank you, dear Brian. I don't know for sure if you're still on, but just bless you, dear Brian. You know, and from my point of view, this is a little bit funny. From my point of view, I sort of feel that I am so busy evolving in my thinking that, I mean, what I'm thinking today is even different and more evolved than what I was thinking yesterday. And I've already made a few changes, even today during our talk, I've made a few changes on my slides that it's not ultimately growth impeding, but it's even right now. And ultimately growth impeding. I mean, the defenses. I mean, I'm so busy evolving and refining the nuances of my ideas. Although I run into people who had heard me teaching 30 years ago, 35 years ago at the Boston Psychoanalytic Institute and other places, and they say, oh, wow, you know, it's great to hear you again. You know, you were saying that 35 years ago, which is both sort of like, oh, that's good. At least I'm not completely contradicting myself, but also sort of like, wait a minute. I thought I'm like totally evolving and ever busy refining my ideas. I will tell you one thing that Laurie Scheck had pointed out to me. I used to say, wait, I'm talking about thinking about challenge and support. Let me just see if I can possibly remember what I used to say and think about what I now say. And now I say do both. But I used to say challenge when possible, support when necessary. Then I think there came a time when no, I think I used to say support when necessary and challenge when possible. Then there came a time when I said support when possible and challenge when necessary. I don't know. But now I say both, challenge and support to get this match experience going. But anyway, bless you all. And thank you, Brian. It's a special treat for me to have Brian here because it just is. Okay. He lives in Bermuda, which is another country. That's another country. I often make the mistake of thinking that Bermuda is part of the United States. It is not. And listen, for people on the East Coast and North Carolina and that hurricane, you know that my thoughts and my heart are with you. You have to know that. A lot of people just think, you know, another hurricane. I don't think, you know, another hurricane. The hurricane season is fast upon us. Okay, there's Brian, and he lives in Bermuda, so, you know. Okay, Ed, thanks, Martha, for the affirmation of my statement. You might want to know that that marriage was ended 25 years ago. Sadly, oh wow, an immensely painful situation for her. Boy, has she not gotten over that. She is making some progress, especially when she gets a present sensation of safety and freedom, like she gets when she's with you, Ed. You'll listen to this later. Sorry, I have to go. Wonderful presentation. Thank you. All right, well, listen, you dear people. Thank you. Thank you, thank you. And I know we're getting near the end of summer and so on, but I hope to see you back here. And you got to sign up. Now, if I could be so bold and kind of gentle about it, you know, if people sign up, not just like 15 minutes before it's supposed to start, you know, if you could like start up a little earlier than that because I'm like busy scrambling, like, oh my God, I got to get you in whatever and get you the link and get you whatever and get you registered. So if you could maybe, although most of you all, I think, were really good and signed up. Let me just see. All of you, yeah, and Joel signed up way in advance. And yeah, you others were really good. Oh, I could see Judith in person. All right, let me just see. I think you, yeah, Carol signed up way in advance. Thank you for that. Anyway, so there you go. Hello, Gail. She is still here. All right. So listen, you all. I send you my love, and I look forward to seeing you all down the road. Bless you. All righty. Bye bye. Uh, oh, thank you. Thank you. Thank you. Now, how do I end this? Well, I don't know how to end this. Um, oh, okay. All right. My chat was covering it up. Okay, end.